Okay. Good evening, everyone. Thanks for joining in on this webinar, Responding to Vaccine Hesitancy on the Front Line. I'm Dr. Kathy Mitchell-Moore. I'm a GP based at Lakeside Medical Practice in Warilla, and I also work with Coordinare as a member of the Illawarra Shoalhaven Clinical Council. I'm going to be the chair for this event, and we're just going to start in a couple of minutes, but first we'll have an acknowledgement of country. I wish to acknowledge the traditional owners and custodians of the land we're meeting on today. I pay my respects and honor to their elders past, present, and emerging, and implicitly acknowledge their continuing connections to their ancestral lands. Great. Okay, well, we have a lot of people who've logged in. I think everyone will agree that this is a highly topical subject, and there's been a huge response in registration for this webinar. This evening, we have GPs, nurses, aged care workers, practice managers, receptionists, and other frontline clinical staff who are logging in from all across New South Wales and the ACT. I think this demonstrates how keen everyone is to discuss questions around the COVID vaccination rollout and how much people want to obtain reliable information which can be imparted to their patients. For this evening's event, we have 3 speakers, and the presentation is going to be divided to focus on different sections. First of all, we're going to have a talk about COVID vaccine safety. Then there'll be a brief discussion on the opportunities and challenges in vaccine delivery from a general practice perspective. And finally, there'll be some practical advice on how to engage those who are vaccine hesitant. Each presentation is going to be around about 15 minutes, but then there'll be time for questions and answers. And I will pose those questions to our expert panel. There's been a lot of questions which were submitted in advance of this webinar, and so hopefully a lot of those will be answered during the presentations, but you can still submit questions using the Q&A box on your screens. And if you keep the chat box open during the presentation, you'll also see links which will direct you to some reliable vaccine information. So let me tell you a little bit about our speakers. First, we have Professor Christine McCartney, and she's going to be telling us about vaccine safety. Christine is a pediatrician specializing in infectious diseases and vaccinology. She's currently the director of the National Center for Immunization Research and Surveillance. She's a pediatric infectious disease consultant at the Children's Hospital at Westmead and a professor in the discipline of pediatrics and child health at the University of Sydney. She's the senior editor of the Australian Immunisation Handbook and is a member of the Advisory Committee on Vaccines for the TGA, the Communicable Diseases Network of Australia, and the Australian Technical Advisory Group on Immunisation. Christine has acted as an expert consultant to the World Health Organization, and she also leads the Australian National AusVac Safety Surveillance Network. And she's a founding chair of the Australian Regional Immunisation Alliance. So I think she's eminently qualified to bring us up to date on any of our questions to do with vaccine safety. Our second speaker will be Dr. Duncan McKinnon. Duncan is a practice principal with Bega Valley Medical Practice, and he's the GP liaison officer for the Far South Coast region. He was recently named the RACGP GP of the Year for 2020. So we actually have a celebrity with us today, in part for his leadership in coordinating the local health response for his community during the 2019 and 2020 bushfires. Duncan has an active interest in making general practice sustainable and professionally rewarding with an emphasis on education. And he's a part-time senior lecturer with the ANU Rural Clinical School. He's been a GP for 25 years and a supervisor for 10 years. He's an early adopter of new approaches to improve patient care, and he's going to bring us a real frontline perspective to our discussions. And then we'll have Professor Julie Leask. She's a social scientist and professor in the Susan Wakil School of Nursing and Midwifery for the Faculty of Medicine and Health at the University of Sydney. She's also an advisor to the World Health Organization on improving vaccination and is affiliated with the School of Public Health and the Marie Bashir Institute for Infectious Diseases and Biosecurity at the University of Sydney. Julie's going to be talking about how best to engage and communicate with people who will be hesitant about becoming vaccinated. So with no further ado, let's start our discussions and begin with Professor Christine McCartney.
Oh, Kathy, thank you so much for that very warm welcome, and it's an absolute pleasure to be on the webinar this evening with yourself, with Duncan, who I'm very much looking forward to hearing from, and with all of the audience who I know are working so hard on the front line. I'll just swap my view here, and hopefully you can see my slides clearly now. Great. Okay. Well, look, I think I've got about 15 minutes or so. I'm very conscious of time, and there is, quite a lot to go through with these vaccines. I'd just like to point you to our website at NCRS as well, because there's a lot of resources there, and I know Lauren Dalton from our team is going to be pointing some of those resources in the chat, putting some of those there. So a quick update on the disease, on the vaccines, and on safety and effectiveness. I would like to do this by beginning with acknowledging any Aboriginal and Torres Strait Islander people who are with us today, and our First Nations people as the traditional custodians of the land, and pay my respects to them this evening. So, look, we know COVID-19 is continuing to cause absolute devastation across the world. I think we've seen this more than ever on our television screens. We know that we have a precarious hold on keeping the virus out of this country, and cases, despite so much hard work around the world, are continuing to rise, and they're particularly rising in our region. It's quite sad to see, but after so many months of keeping the virus out, countries like Fiji, Papua New Guinea, Timor-Leste, and then, of course, even larger countries like India really battling with the virus here. You can see data from the Western Pacific region and the Southeast Asian region. So I think more importantly, what we do know is that COVID is with us now, but SARS-CoV-2, the virus that causes it, is also going to be with us for our lifetimes. This virus has too many sneaky properties. It's, got a proportion of people who it infects who are asymptomatic, or mildly symptomatic, and they can go around in the community. And, then there are other people who become obviously incredibly unwell and will pass away in great numbers because we're completely naive to this virus. It's a brand new virus. So we are going to need to turn this into an everyday mild illness. And how do we generate immunity without causing great harm to ourselves through letting the virus spread and cause loss of life? Well, we vaccinate. And we need to vaccinate as absolutely many people as possible, and then boost them if needed. So, vaccination isn't going to, in 6 or 12 months, wipe out the virus from the world, but what it will do is build up our immunity. It's going to reduce serious outcomes, reduce our likelihood of developing illness from the new variants of concern. Even if the vaccines are just slightly less effective against the variants, they're going to give us, strong partial protection to reduce those variants, help us build up immunity. We are seeing strong evidence every day now from studies in other parts of the world that these vaccines will help reduce transmission. It's a bit of a no-brainer in the way. I know that this was talked about a lot in the beginning of, we don't know whether they'll stop us reducing transmission. But if you think about it, if you're less likely to become deathly ill, go into a hospital, have a lot of coughing, right away you're going to reduce transmission. But then we're also seeing this in some new studies that I'll show you. And, of course, reduce our reliance on these, really strict public health, quarantine and other measures. So I know Julie will talk to you about this, motivations for vaccination. They will vary, but I think it's really tapping into this for our friends, our family, our patients, our community to understand, how we can be sure that we can all have the benefits of vaccination. So let's talk about safety and effectiveness. And firstly, I do hope you're familiar with this website. I'm completely biased, of course, as you heard, but this is Australia's active vaccine safety surveillance system. It's been running since 2014. And if you jump on this website and go straight click into the data on COVID-19 vaccines, you'll see that we've now got surveys back from over 400,000 participants, and perhaps people in your own general practice or in a clinic where you're giving the vaccine. Across the country, we've had, hundreds of thousands of people, obviously, and also Aboriginal Torres Strait Islander people. So if you're in a clinic that sees our First Nations Australians, then we have, great participation here from Aboriginal Torres Strait Islander people, and I can assure you that the safety of the vaccine in our First Nations people is looking as good as it is in all others. And similarly, although we don't have this on our website, important to note that we're also asking people, do you have a chronic medical condition? And if they say yes, we ask them to tell us what it is. We analyse responses by underlying medical condition, and we are not seeing any difference in the survey responses at day 3 or day 8 after vaccination, both doses, for any difference in those with chronic medical conditions. So the way the data looks is pretty much, so for AstraZeneca dose 1, this packs a bit of a punch. About 40% report no adverse event, but on the flip side, around 60% will say, yes, I had, came on that evening, lasted for a day or two. I did have fatigue. I had a headache. Some people will actually have chills, joint pain, fever. But of course, this is the vaccine stimulating our immune system. Some people will need to, change their usual duties for a short time afterwards. Some might check back in with you. But if we tell our patients about these expected side effects, so make sure they're not planning to, get out and run a marathon the next day. These are short-lived. They go away within a few days. For Pfizer, dose 1 is, less reactogenic, we call it. So only about, a little over a third of people having an adverse event. It's actually the number down here on the left, 38%. But that dose 2 actually packs a bit more of a punch if you've had Pfizer dose 2. So here around 60% of people will have the sort of same systemic symptoms, fatigue, muscle ache. This is data you can pop up on your screen when you're talking to people, explain to them that these are expected adverse events. Okay. I think this has come a little bit out of order, but it is about the effectiveness of the vaccine. So what I wanted to show you here, and this is a really complicated looking graph, but this is one of a number of studies now from the UK. There are studies from Israel, from the United States, from Bahrain, from other places. But the UK is particularly interesting because, of course, they're using both Pfizer and AstraZeneca, and they've done some really elegant studies. This particular one is in households. So if you look here at the dotted line and you say this would be your, likelihood of getting COVID, and then you look here, this is the odds that are reduced. So this is the reduction. You're less chance of getting, COVID if you are in these categories. So if you're vaccinated, then you look down to the bottom here, more than 21 days after the first dose of Astra, more than 21 days after first dose of Pfizer, both looking quite similar. Post second dose of Pfizer, again, very reduced chance of getting COVID-19. And that's actually quite similar to the disease itself. So if you were previously positive, that is, you'd had the disease in the past, you're not likely to get COVID as well, you're about equally protected here. Now, I won't go through all of these dots, but what I can tell you, and you can see, is there's a huge volume of data here that's looking at how much virus people had detected in their nose or throat swabs. So there were more likely to have a lower amount of virus, which means you're less likely to transmit or be shedding high amounts of virus that might pass on to others. And you were less likely to have symptoms as well if you're vaccinated. But you were also protected against asymptomatic infection. So a huge volume of data in this just one publication, but there are others as well. And I think what this is telling us and what other publications are telling us, this is a household study, by the way, and done prospectively by swabbing households over a period of time. Really, in these UK studies, there hasn't been a difference between AstraZeneca and Pfizer vaccines. And I think this is important because, some of the patients will come in and say, oh, I heard AstraZeneca doesn't work as well. It's not as good as Pfizer or, something like that. But really, the real world data is telling us that both vaccines are performing very well in the UK. Certainly these sorts of reductions, which are quite significant, protecting like previous infection did. No difference by age either, no difference in healthy versus chronic conditions, and definitely an impact on viral shedding symptoms and asymptomatic infection. And some other studies that I haven't been able to show you in the short time here, showing a reduction in transmission, as well as reductions in the impact of virus variants. Now, I'm not going to talk a lot about the variants of the virus this evening, but, there are different studies showing you might have a higher antibody titer that you need, or an antibody titer, you don't inhibit the virus as much. But most of the real-world effectiveness data is still looking pretty strong, and there is the capacity to tweak those vaccines in the future, which is the most important thing, because there is a strategy for dealing with the variants. But first and foremost, let's get on board with the vaccines that we have. Okay, so what about this rare, new, unusual syndrome that's been reported after AstraZeneca vaccine? Not seen in clinical trials, but found after safety monitoring in millions and millions of people. And that tells us right away it's rare. It also tells us, incidentally, that our safety systems have been working. And it's important to note the red down here on this slide that is true at the present time, and I think for the vaccines we're using at least will continue to be true, but no other major safety issues found. So yes, some cases of anaphylaxis, but not more than other vaccines. Yes, there have been reports of all other sorts of conditions, but they're conditions that occur at a normal background rate in the communities, and none of them have been causally linked to the vaccine at this stage. So this condition, though, is rare development of an immune thrombotic thrombocytopenia that appears to be mediated by these platelet activating antibodies. And the only thing that it's somewhat like is heparin-induced thrombocytopenia, which isn't uncommon in the adult population admitted and given heparin in hospital for something. But of course, these patients haven't received heparin. So I'll go through this in a little bit of detail. What I have here is a picture of the cerebral venous sinus sinuses, the draining veins of the brain, because it was in patients who had clots of these veins that the condition first showed up in Europe. But I can't stress enough that it is a unique new condition, and it is thrombosis with low platelets. Normally we see thrombosis not with low platelets, and it's just a completely new out of the blue condition. In unusual sites, I've already talked about cerebral venous sinus thrombosis, sometimes the splanchnic or intra-abdominal vessels or other sites, mostly venous, less often arterial. Bleeding can be significant because the platelets are clumping and getting consumed. There's a very raised D-dimer, and importantly, antibody to platelet factor 4. So if you see someone with clotting and with low platelets, put the two together and call your haematologist. But you're unlikely to see them. We're going to talk about the rarity of it in a moment. So it is a severe condition, around a 20% case fatality rate, but less with early recognition, and that's very important. Onset 4 to 28 days after vaccine, around the 2 weeks, 1 to 2 weeks is probably the peak time. But note this 4, this is not in the first few days. It takes a few days to even develop the symptoms of this condition. So once people are over those initial side effects. And the patients don't have risk factors for clotting. There is nothing that can predict whether this will occur, except slightly greater in younger age. Mainly seen after dose 1, extremely rare after dose 2. Actually, this should say 6 cases in 6 million. I apologise, but so it's still 1 in a million chance after dose 2, and we're still even not sure about some of these cases after dose 2. So we're at the moment continuing to recommend dose 2 if you've received dose 1 of AstraZeneca, no matter what age you are, because of the rarity. So how rare? Well, let's sort of kind of cut to the chase here, but 22 million first doses, that's almost the Australian population that's vaccine eligible in the UK, and they've seen 242 cases, and they've continued to use AstraZeneca. Age ranging from 18 to 93 years, And they've now, they certainly haven't vaccinated anyone, but they've gone for a preference for a non-AstraZeneca vaccine at a younger age than us. It was initially less than 30. Now they've made it less than 40, mainly based on the fact that they've got very little to no COVID now. So they're going less than 40. We're going less than 50. Europe's got similar sort of rates, and Australia are reporting data every single Thursday now out of the TGA as a routine. As of last week, we had 11 cases, 5 less than 50 years and 6, more than 50 years. Now, we will see some more cases reported, as you can imagine. This rate of around 1 per 100,000 doses. So 6 to 10 cases for every 1 million people vaccinated does mean that we will see more cases as we vaccinate more older Australians with AstraZeneca. But you're unlikely to see one. We're all unlikely to know someone who's had one of these, in our circle of patients or friends, because it's so rare. So, for that every million that we're going to vaccinate, most won't have this condition. But it is slightly higher in younger adults. And for this reason, in those people, Pfizer is preferred over AstraZeneca. Now, I'm not going to go into this algorithm. It's on the Thrombosis Hemostasis Australia, New Zealand. So if you just remember Thrombosis Society of Australia, you'll find it. And it's all about, if you did happen to have a patient, you're telling them as a routine, if you're unwell in the coming, month with very severe headache, after you get over those initial side effects, any abdominal pain, severe abdominal pain, something new and severe, or low platelets, then we'll look for this, and we'll look for either low platelets or clotting. But there's a flow chart here of how they're managed. Key thing is don't give heparin and consult the haematologist. So we don't know the mechanism of this condition yet. It's not the same as usual clotting conditions. It is likely mediated through this antiplatelet antibody. There's no link with COVID disease itself, and it is seen with another adenovirus-vectored vaccine. This has only been discovered in the past 1 month. So very rare cases also seen with the Janssen vaccine, which is also an adenovirus-vectored vaccine, not seen with Pfizer or Moderna. But the big news and the most important thing in clinical practice is that there are no risk factors that can predict who will get this, other than it being slightly more common in younger people. This means that you can give it to, it's a different mechanism, and we don't see the people who have it as having clotting risks. So you can give to people with clotting risks. You can give to someone who has, a clotting risk factor. You can give to someone who has, this is AstraZeneca vaccine, of course, you can give them AstraZeneca vaccine if they have a history of thrombosis or if they have a history of low platelets. The only exceptions, and this is only very precautionary, is we're recommending Pfizer if you specifically have a history of heparin-induced thrombocytopenia or specifically have this unusual type of thrombosis called cerebral venous sinus thrombosis, which can occur at a normal background rate. So who's preferred to receive Pfizer over AstraZeneca? Well, it's only aged less than 50, only pregnant or breastfeeding, who are mostly less than 50, past anaphylaxis, or indeed if there's only been a handful of these, but vaccine-associated thrombosis, thrombocytopenia. So weighing up the benefits compared to the harms is really important here. And you're in general practice, whenever you prescribe an antibiotic, whenever you suggest someone, might go and have a colonoscopy or they have an anaesthetic for another reason, each of those things carry a risk. And we tend to sort of not worry about those as much because we know them and we take them for granted. But here the big benefit is prevention of COVID. This is how many ICU admissions will be prevented on the left. This is a low exposure to COVID scenario from the UK. And we've also got this for Australia, but we're in the process of updating at the moment. The reason I show this one is because it's got the latest by age, decade of age, risk estimates for clots on the right-hand side. And to be honest, our rates are, still based on small numbers, but they're looking almost exactly like this, as are rates out of Europe as well. So this is a pretty good rate. And you can see here why we've cut off at the 50-year age group, because really the benefits are quite outweighing any risk from 50 and above, and even more so if you go 70 and above. Okay, so quick few questions before we wrap up. Pregnant, Pfizer preferred. Breastfeeding, Pfizer preferred because you're younger, slightly higher risk of TTS. Immunocompromised and over 50. Look, recommend your patients to receive AstraZeneca vaccine. They're at high risk of COVID. They're going to do, just the same sort of early side effect profile as if they weren't immunocompromised. Obviously, don't give it to them if they're, just had a cycle of chemo and they're about to be profoundly neutropenic. You might want to think about the timing, but otherwise, yes, recommended for AstraZeneca vaccine. Autoimmune disease, yes, recommended for AstraZeneca vaccine. These individuals are at higher risk of COVID. I mean, were they to, go into the coffee shop or the supermarket where someone with COVID, just stepped in, they're the patients who are at risk. They might be the ones in hospital. What if they don't want AstraZeneca and want Pfizer? And we are, of course, doing this through an informed consent process. Well, you have to wait for Pfizer if you don't want AstraZeneca now. It's as simple as that. Can I tell you how long you have to wait for? I cannot. But you will have to wait because the supply of Pfizer is it's low and slow. I mean, I don't know whether I would get away with saying that if I was on a Commonwealth government webinar, but it's a supply that is only slowly growing over time. So right now, Pfizer is certainly being preferenced for the under 50s and those at highest risk under 50. Okay, my patient is under 50 and they had dose 1 of AstraZeneca but don't want dose 2. Well, they are recommended at this stage to have dose 2. We don't have information on, 1 dose of Astra followed by 1 dose of Pfizer. So would be working in a pretty evidence-free zone there. And we do know that by far and away, Astra is very safe for them. So that's the current recommendation. If they wanted to do something differently, they would have to wait. Oops. Oh, yep, here we go. Look, should I wait is the answer. And I can understand people are thinking, should I wait? But, if you wait, you prolong your chance of being able to be infected by COVID, and it's going to take us all longer to get out of this. So, I think it's really important to consider the vaccines. If you wait for Pfizer, it could be many, many months. We just can't predict when that'll be opened up more widely. Will I need a booster? Look, these vaccines are looking quite protective out to at least 6 months. This is brand new, of course, vaccination, so we need time to study. But these studies are absolutely ongoing. There's already a couple of companies that are looking at a booster dose, but we don't yet know if and when that'll be needed. I suspect it will be for those at high risk, in particular older people, those with chronic conditions. Going down the age spectrum, we've just had Pfizer vaccine registered in North America for age 12 to 15, and we expect that age group will be opened up for registration in Australia coming soon. But of course, they are even less likely to get severe COVID, so they'll be down the track. But we may well need to vaccinate, children to be able to get the optimum protection in the population from a herd immunity perspective. We've already done, I think, the immunocompromised one. Yes, higher risk of COVID-19. The main contraindications are very limited, only past anaphylaxis or allergy to the ingredients or a mast cell activation disorder. Just be aware of, because you can be at slightly higher risk of anaphylaxis.
I might interrupt you there.
Good, because I will stop my questions. I could go on with the questions for a long time, but it might be more fun to do those interactively. So I'm really happy to wrap up. Oh. And my last slide is some resources and a hug that we're not in this situation, but let's vaccinate so that we don't get there. Okay.
If the other panelists would like to come on live with their videos, if possible, if you want to join in with answering some of these questions, we're getting quite a few questions through in the Q&A. So I'll just start going through them. There's a question, someone's asking, if you contract COVID-19 disease, for how long are you considered to be infected?
Was that infected or protected?
Infected. If you have COVID-19, how long you're infected, wants to know.
Oh, okay. So look, usually it obviously depends on the individual patient, but once your symptoms have resolved, there are guidelines on whether you need to be tested, and of course that depends by which country you're in. If you're in Australia, you'll be closely followed up by public health. So the duration of illness depends. It can be a week or two. People can sometimes shed the virus for a little while afterwards, but they're often tested afterwards here in Australia. How long you're protected, we don't know for sure yet, but it does appear for most people who've had COVID would be around 6 months. So if you're thinking about, you had COVID when you're here or you're overseas, should I be vaccinated now? We're suggesting to wait around 6 months. And obviously, we don't know. We're still suggesting to be vaccinated after you've had COVID, but you can wait a while because you're probably protected from your illness for a while.
We have someone asking, saying that, let's just try and phrase this question, and that say large areas of Australia now are at risk of COVID, and what's the risk-benefit ratio for the vaccine now? I suppose that really is a question about if there's more COVID, does the benefit of the vaccine go up as opposed to the risk profile? I think that's probably the question that's being asked there. But the next part of the question is, what happens to patients who don't die from the clotting side effect? I suppose that's asking as to whether or not they've been recognised long-term effects from this TTS syndrome.
Look, none that I'm aware of. No long-term side effects from TTS. It's not very many people who've had this, obviously, but many have recovered, and we don't think it's a chronic or recurring condition. We think it's just your platelets have been knocked around by something and then they get better. But we will learn more about that over time. With respect to the benefit risk, Julie may want to add, but I think we are all going to face COVID. I am certain we will all meet this virus in our lifetimes. It is just here to stay. So it's really, in so many ways, more about, am I going to choose to be vaccinated or am I going to choose to take my risk with the disease and risk passing that on to others and letting it spread in the community. So, vaccination is just the great way to get protection on board, reduce your personal risks, your risks to others. And it's our quickest and really only big ticket out of the pandemic. So it's about needing to take it sometime. And, us giving our patients, I think, lots of opportunity to discuss when that's going to be, hopefully sooner rather than later.
Okay, someone else is asking, what's the actual treatment for TTS?
Okay, so you're speaking to a non-haematologist. Duncan, jump in here. But, no, look, I've learned more about this than I would have imagined. But because, so not heparin, so it's a non-heparin anticoagulant, and there are ones like apixaban and another number of others that, again, we're in haematologist territory now. So you don't give heparin as the anticoagulant, you give a non-heparin anticoagulant. You can give IVIG, you don't give platelets if you've got the low platelets, and you can give steroids. And most importantly, there's sort of other just monitoring and things that you need to do. But early recognition is really important. But remember, it's so rare. Just tell your patients, if you're really unwell, when you go in to get checked up, say, I just had the vaccine 2 weeks back. My tummy's really sore. Then we twig to do that, whether, no matter where we are, hopefully we just have that check of the platelet count.
There's a question here about the interval for AstraZeneca vaccine. So some people are having a first vaccine and then they're planning to travel or they're going to be somewhere else, and they want to know if they should be having their second dose earlier than the recommended 3 months.
Go ahead, Duncan.
Yes, so look, I think the evidence is that they get better immunity if they wait for the 12 weeks. And to be honest, in 3 months' time, you're going to be able to get it anywhere and everywhere. So I don't think it's a problem. I don't think access is going to be a problem.
There's a couple of questions about people asking, saying, can they ask for Pfizer even though they qualify for the AstraZeneca? And I think you've already answered that, Christine. You said really Pfizer may become available later, but it's there's no guarantee as to the time you're delaying your time that you're protected. And it's my understanding that in the first instance, the Pfizer vaccine will be geared towards people under the age of 50?
Yeah, yes. I was going to let Duncan, do you want to jump in?
Yeah. Look, under the age of 50, I think the whole issue really is that you can't even buy this vaccine. You cannot, there is no black market for it. So, I've come across people who said, look, I can arrange anything, I can organise anything, I'm going to wait for this. But actually, because of its peculiar need to be stored and it's, the cold chain issues, you just cannot even purchase this if you've got all the money in the world. So the answer to the question is we are stuck with the federal government restrictions and the rollout and the delivery of the vaccine to Australia in general. And I think we have to just suck it up and run with that.
There's another question here. Is it all right to have the AstraZeneca vaccine when you're on a Humira injection?
Yes. Yeah. So there's really, so the flip side of that is, if you just sort of remember the anchoring thing is there's nothing that contraindicates AstraZeneca vaccine unless, you're acutely unwell. I mean, if you're in hospital and heading to ICU for some other reason, like sepsis or something right now, I wouldn't vaccinate you today. But if you're, relatively medically stable, you're not acutely being admitted for something else, yes, get vaccinated. And Humira, any other disease-modifying agent, any other biologic, methotrexate, any immunocompromised patients, all recommended. And all of these people have been vaccinated, tens and hundreds of millions of them around the world. And we know that, it's so important to have the vaccine on board because of the risk that they face should COVID come into the community, which it could at any day.
And just following on from that, someone's again asking, can you give the vaccine to someone who's had a recent DVT or pulmonary embolus? And I would presume that's yes, because it's not the same process. It's a totally different disorder and not associated with that kind of venous thromboembolism. Is that correct?
Yeah, that is correct. And to be honest, look, I'm not sure that's a message that we've gotten out well enough. We talked again today, but we really have to stress this is a different mechanism. And I use the term idiosyncratic, and then someone told me today, that's too complicated a term. But I like it because it sort of just means random. If I was a teenager, it's just out of the blue. We can't predict it. It's a different mechanism. I mean, obviously, if they just had a pulmonary embolus like last week and they're just out of hospital, I'd wait for anyone who's just acutely ill, just make sure they're relatively well again, but absolutely no, not a precaution to giving the vaccine. Can give them the vaccine.
Can I just comment about the immunosuppressants? The only information that's come out from the rheumatologists is if people are using methotrexate, they can omit a dose because they get a better immunological response if they omit a dose. So that's okay to do. And the only other consideration is someone who's on active chemo if they are neutropenic, because if they get an adverse reaction that's not TTS, it's hard to tell whether they've got a febrile neutropenia or whether they're having an adverse reaction to the immunisation. So if someone's on chemo and they're neutropenic, that's a relative contraindication, and for a couple of weeks, until their neutrophil count comes back up. Okay,
and just following on, I'm just reading another question, and I think this has been answered, that patients on disease-modifying anti-rheumatoid drugs, do they have to be off treatment prior? And what you seem to be saying is that, yes, they can omit a dose of methotrexate. That might help boost their immune response. But yes, they can have it. And just to clarify that answer, if the patient's on chemo and they're neutropenic, not to have the vaccine at that point. But being on chemo isn't a definite contraindication to having the vaccine. Okay.
Yeah.
Good. And just for the person who just typed on, but who probably wasn't listening, we've already answered that one about recent DVTs. Yes, they can have the AstraZeneca. All right. Okay, and I'm just going to, there's another question here. Perhaps this is for Christine. Do we know the long-term effects of the mRNA vaccines?
Yeah, look, I think, there's no long-term safety issues that have come up with these vaccines. And I think the long-term effects that you're protected against COVID. So, you know, the mRNA vaccines I know have probably been intriguing to people because they're like, oh, a genetic, you know, product going into the body. But in fact, it's just a little, like we deal with apparently, I heard this the other day, thousands of pieces of mRNA that our cells are dealing with all the time that kind of we meet from the environment. And this is like, someone called it a Snapchat, that it's just the code to make the spike protein, gets injected, your cells take it up, and then it just gets completely degraded and gone in the cellular process. And then your cells just start making the spike protein. So there's no integration of, you know, mRNA. There's no long-term genetic conversion. There's sort of none of that. And these vaccines have been, you know, intensely monitored now in places like the United States, who have enormous systems and, as you know, have vaccinated half their population. So no long-term side effects have been seen. Really good safety profile.
Okay. And maybe just a couple more before we move on to Duncan's presentation. I've got someone asking, they say they have a relative who suffered from a Miller-Fisher syndrome, which is a variant of Guillain-Barré syndrome 3 years ago. It's an autoimmune disease. Is it all right for that person to have an AstraZeneca, or would they be advised to have a Pfizer vaccine?
No, again, no, very few contraindications to AstraZeneca, very few precautions. Absolutely. We've done surveillance for Miller-Fisher, and we've looked at it, you know, and as a variant of GBS, and we've looked at it after pandemic vaccines. And it's certainly one of those things that we'll look for, again, with a lot of studies where we're looking out for those things. But we do not think that there's any greater risk of that condition, GBS, you know, any of these types of conditions after the vaccines. All the studies that are coming again out of places like the UK, the US, they're not seeing any signals for any problems at all. So yes to your relative.
All right. And what's the fatality rate from TTS in Australia so far?
Yeah, look, good question. So we've got 11 cases reported so far. And the very first case was a fatal case. And, sorry, no, I'm incorrect. She was actually the third case. I apologise. And I say she, and, you know, but the really interesting news for us as a country is our haematologists are like, they're really onto this. And we are detecting, we think now, slightly milder cases. So it is about being aware. And I did hear a story today from someone that said they went to a clinic and their husband went to the clinic to get vaccinated and the GP didn't mention it. So it is important. It's part of informed consent. We do need to, and it wasn't a GP actually, it was a community-based clinic somewhere, and they weren't told about the condition. So it's important to tell people. It's part of the informed consent process. But, you know, they don't need to go home and worry about it because it's so rare. They just need to be aware of it. And the fatality rates, we think, going to be even lower here than in other settings.
So if I can just clarify that, we've had 11 cases in Australia and 1 fatality.
Mm-hmm.
Okay. All right. Okay, well, I think we'll move on to Duncan. Thank you very much, Christine. That's been fantastic. Obviously, please don't go away because we may need you to answer some additional questions as we go along. Thank you. Duncan.
Thanks, Kathy. Look, I'm just going to take a couple of minutes. I've just got a couple of points, and that's great because we can spend a bit more time answering questions. Look, from a GP perspective, I think it's okay for people to ask questions, and I think we should be encouraging it. They're all valid, and we have to be respectful and non-judgmental and allow people to make their own choice. I think this is an important part of informed consent. The issue is we do have to do our own research of trusted sites and keep up to date. It's really important that we know enough and we feel confident about the information we're imparting. I think ATAGI and New South Wales Health websites are great resources, and there have been a whole lot of resources put in the chat box for us to refer to later. I think, like everything in medicine, you can only run with the accepted wisdom of the day. And currently, you've just heard it delivered tonight. Remember, some of our specialist colleagues are not vaccine experts, and many have spoken outside their field of expertise. So stick to the advice from ATAGI and New South Wales Health, and you can't go wrong. In Australia, infection numbers are low, but with vaccination and time, we'll not be able to detect community transmission when it happens. and then it will be uncontainable. And the only people who will die from COVID are those who get infected but remain unvaccinated. If we lose control, we won't have the capacity, the resources, or vaccine to vaccinate everyone who want it. And even then, you still need time to be immunocompetent. My personal experience is that about 75% of people who initially refuse to be vaccinated, if respected, are happy to consider it. 20% will go away and think about it. And like always, 5% will refuse in the moment. But I think it's really important that we give people accurate information the best we can, and we feel confident about doing it. Thanks, Kathy.
Okay, Duncan. So I've got a couple of questions which probably you may be able to answer for us. If you have an interval between the AstraZeneca doses which is exceeding 12 weeks, is that going to be a major problem for anyone?
No. Yeah, I don't think so. I think it's. I think 12 weeks has been shown to actually improve your antibody response, but I don't think after that, just get the second vaccine.
And a couple, and I'm not sure how easily you'll be able to answer these, but perhaps you can direct people to where they might get the information. There's a few questions about people having, who want to get the Pfizer vaccine. Someone who's traveling for a family crisis, they're under the age of 50, but they don't actually fall into the bracket of being a phase 1A or 1B worker. Is it at all possible to arrange for someone like that to get a Pfizer vaccine?
I have to stick to the New South Wales Health advice, and that is, and the federal government's restrictions, and that is no. I would say no.
Okay. I think someone else has asked a question about saying that their husband is 67 but can't get their first vaccine until late July. I think that's more of a complaint really than a question. I suppose we're responding to that by saying that with vaccine hubs coming on board, hopefully that's going to be less of a problem as we go forward. Someone else has asked a question, again, I'm not sure we have the answer to this. Is Pfizer vaccine being diverted from residential aged care vaccination program to the under 50s cohort?
No, it hasn't been. It has been suggested. In my book, it makes perfect common sense, but it's been deemed to be politically unacceptable. And so they are getting Pfizer.
Okay.
The only thing I would add to that is I think it is sort of in train. And look, it's really interesting, isn't it? Because my own significant other who's over 50 booked in with less than a week, and I'm sure it really depends on where you are. But I think what we're seeing is a greater volume of doses now. So just as you said, Duncan, talk to your patients, tell them not to despair. Some of those early frustrations about booking in or not finding the clinic had the vaccine, they're difficult for people, aren't they? But don't get frustrated by those. Keep persevering, and maybe that patient who's got the booking for July, if they called up, they might actually be able to get a sooner one, an earlier one now, because with more vaccine coming online.
And we've been offered lots of vaccine. In fact, we've been offered as much as we'd like to ask for, and we can't. We just cannot deliver it. So, to be honest, I would rebook somewhere else.
All right. Here's an interesting question, and I think this is something which is quite confusing, if not for health professionals, but for the general public. They want to know why there are different age cutoffs for AstraZeneca between the different countries. Why in one country do you have it if you're over 50, but in another country you have it if you're over 30? And I think that those discrepancies sometimes undermine people's confidence because they say, well, why is it different in different countries?
Look, I'm going to back to Julie after this one because she's been patiently waiting, but she might have to add. But, there are many countries that have no age restriction at all. I mean, countries that are battling COVID right now, it just doesn't make any sense. Your chance of becoming ill from COVID, dying from COVID in coming days and weeks is is so much greater, and they don't have age restrictions. And then there are, other countries that have gone with the age of 60, some with 65. Canada went with 55. Now I think they've come down to 45. Someone could Google what's Canada now. The UK went with 30, and then they've gone up to 40. We've stuck with 50. Now it is confusing. I mean, I think it is a bit confusing, but it's really what the World Health Organization is saying, what everyone's saying is, look at your own context, look at your own supply, look at your own distribution, look at your vaccine alternatives, and, look particularly at your risk. And the single unifying factor is we want our populations to be protected as soon as we reasonably can, and with the best benefit and the lowest reasonable risk. That's where ATAGI set the bar. I can tell you, we talked about every age intensely over about a week, and we still meet every week and we talk about, is the age right? But we think it is. Now, remember, it's not a black and white. So if you're 45 and you really want to get AstraZeneca, the numbers on either side, you can choose to have that discussion as a GP with your patient and your patient with you, and have AstraZeneca. But if, unfortunately, just with the supply at the moment, if you're 55 and you say, I'm choosing not to have AstraZeneca right now, you will have to wait for Pfizer, because we have less Pfizer, and there is a movement to getting those Pfizer doses into, the younger population, particularly those at risk in the younger population, and with Pfizer hubs opening up for younger people. So I don't know whether that's a good answer, but it is about every country looking at their own particular settings. And I don't know, Julie, if you wanted to add more. But
well, I think that might be a good point there to move on to Professor Julie Leask and have her give her presentation on now that we know that the vaccine is safe, and we know that there are very few people that can't have AstraZeneca. What do we do about dealing with vaccine hesitancy, and what are some practical solutions for that? So I'll hand over for Julie to give us some advice on vaccine hesitancy.
Thanks very much, Kathy, and thanks also to Christine and Duncan for giving all your information and expertise as well. First of all, and most importantly, I'd like to acknowledge that I'm sitting tonight on Darug country. I'd like to acknowledge the traditional owners of this country, their elders past, present, and the elders of the future, and any Aboriginal or Torres Strait Islander people who have joined us this evening. I'm going to just share my screen now. And this picture celebrating International Nurses Day. This is Kath Cannings, clinical nurse consultant. She used to work at NCRS, National Centre for Immunisation Research and Surveillance, when I was working there as well, and where Christine remains the director. And this is she and I having a discussion about my flu vaccine some years ago. So it's lovely to be celebrating nurses, and I think she certainly has made a lot of contributions to the area of vaccine safety. So I'm going to talk about communication. I went through your questions. There are about 97 questions for the webinar tonight. A lot of them were on safety, but there were quite a few about what drives vaccination. So I'm going to look at that, how we address hesitancy and communicate risk and benefit well, and how we address misinformation, which is a perennial challenge. So first of all, in terms of what influences vaccine acceptance, the National Centre for Immunisation Research and Surveillance have a social science unit, and the team there, Mareka Steffens and Kasia Bolchevich, have put together a review of the literature on what influences COVID vaccine acceptance, because we already are starting to learn that with research. And what the worldwide research tells us is this: that first of all, people, if they're hesitant, and this is what causes hesitancy, it's going to be safety concerns primarily, particularly those concerns that some of you have about the long-term impacts of the vaccine, and the short-term impacts and the actual risks that we've been talking about tonight. People are concerned about whether the vaccine will be effective enough. In other words, is it worthwhile having it? They're not so tolerant of the uncertainty that we have this early stage in the vaccine program. They believe perhaps that there's a low risk of COVID, which technically right now in Australia there is. So it might not be worth having the vaccine. They sometimes doubt the assertions that the pandemic is serious. They may even have subscribed to misinformation or conspiracy theories, which is quite common in this unsettled, uncertain time in our lives. They might have a lack of trust in various stakeholders, those who develop vaccines, those who recommend them, governments, and they may find that there's a lack of information for them to make a decision. So this is what intentions to vaccinate are estimated to look like in Australia. This is from Essential Research. It's showing similar results to other studies. So this is showing you what intentions in Australians to have the COVID-19 vaccine looked like up until the 15th of March. And this is before that announcement about the AstraZeneca vaccine. So we started in August with high intentions, and the red is people who get the vaccine as soon as possible, or more recently, I've already had it. The grey is I get the vaccine, but I wouldn't do it straight away. And the black is I'd never get vaccinated. Now, what's interesting is that never get vaccinated group has increased slightly, and it's a bit jumpy. So it shows that when people say they'd never get vaccinated, they may change their minds. As Duncan has pointed out, if concerns and questions are addressed well, people can change. In fact, it's probably only about 2% of Australian adults who plan to not get the vaccine because they're against vaccines in general. Okay, so what happened after the announcement about the change in recommendations to prefer Pfizer for the under 50s on the 8th of April? You'd think that there would be a big plummeting in intentions to vaccinate, but there wasn't. There were definitely fewer people wanting to vaccinate, but there were more people just saying, I'll put it off for the time being. And there was also an increase in the percentage who said they'd never get vaccinated. So there is hesitancy out there, and your role in addressing it is very important. So how can you address hesitancy and communicate effectively? The first point comes from a Gomeroi perspective from the project of Amy Crichton, who was interviewing people in her own community, Gomeroi country, around Tamworth, Inverell, looking at willingness to have maternal vaccines. But this is so relevant for COVID-19 as well, that if you engage with people, if you spend the time with them in primary care answering their questions, that can have an impact on their community and beyond, particularly for highly interconnected communities like Aboriginal and Torres Strait Islander peoples. So this participant said that the service, right, the primary care provider, might have spoken to one mum, but guess who that mum has spoken to in the next couple of hours? 20 mums, and she's passing that information on. You might not have that flash brochure, but the power and the time you've put into her, she's putting that into her friends. So that interaction is important for that person and for the community. And that's why it's important for you as a primary care professional to keep your knowledge about COVID-19 vaccine up to date. Use the resources that Lauren is recommending in the chat. Being here is excellent because you're getting your questions answered, and thank you for sending in your questions. Make sure that your patients have a good quality consent process through your clinic. So that may look like offering them information before the encounter and then offering to answer any questions at the beginning of the encounter, so that if they do have any questions that they want to have a discussion about, they have that opportunity. Don't over-reassure people when they're concerned about risk. It's okay to engage with people on vaccine risk, and in fact, it's important for valid consent, particularly if they're concerned about it. When you communicate risk, communicate not just the outcome and its severity, but how common or rare it is. Use words and numbers, and I'm going to show you an example in a moment. Make a recommendation. It's okay to let your patients know what you would like them to do. Of course, you need to respect their autonomy, but a guiding style can be appropriate with vaccination, given that the benefits are very strong for not just themselves, but for their family and community. And make sure those services are convenient and respectful, as you saw with the previous slide. So the conversation tips for the hesitant, here's just some suggestions. These are tips mostly to show what I'm talking about with some of these practices. So on the left of this slide, you've got different communication practices. And on the right, I've just put in some examples of what that could look like in a COVID-19 vaccine encounter. But of course, you'll have your own communication styles and preferences, and your patients will all be unique. So first of all, it's recommended if someone is hesitant or asking a lot of questions, elicit their questions and concerns until you've heard no more. So don't just stop at the first one and jump in and answer that question and write that wrong thinking, as we say with that writing reflex. But explore, ask an open question like this one. You mentioned earlier some concerns. Can you tell me more? And then acknowledge them and their concerns and validate them. This is very powerful because even with a nod or a brief period of silence or words like it's understandable you have concerns, you're indicating to them that that person has validity in wanting to be careful with their health. And that's a great way to build rapport with your patients, particularly if they're hesitant. You can set a brief agenda. And many people will say, oh, this will take too long. With practice, it doesn't have to take too long. It can actually be more efficient with people who are hesitant because you're looking at their concerns, you're setting that agenda, and then having a conversation with them and signalling time as you go. So you could say, let's go through that concern about the clotting risks. And also I want to talk about the benefits. How does that sound? And then you might hear there's something else that's really important to them to discuss at that point. And you know how to apportion bits of time to that brief conversation. You may need to put off the conversation if it looks like it's going to take too long. Send them away with some resources, but ask them to come back and make an appointment to come back. Sharing knowledge could look like this. There's a risk of getting this rare clotting problem from the AstraZeneca vaccine. It's rare. In your age group, it's about 4 in every million people who will get it, but it is serious too. So here I'm doing 3 things, describing the risk in qualitative, rare, and quantitative terms, 4 in a million, and acknowledging its seriousness, the seriousness of the outcome. But now I'm pivoting to the benefits. But if we had a big outbreak this winter, the risk from getting sick from COVID would be higher for you. And here we're assuming this person will be in the 50 to 59-year-old age bracket. Then it's useful to elicit what's important to them. And there are many people who aren't just thinking about the risks of getting COVID, they're also thinking about the freedom and protection and reassurance that having a vaccine provides them. Of course, it's not an ironclad guarantee of protection, but it's certainly going to help a lot. So helping them engage with the benefits of vaccinating and the things that might motivate them is also useful. Then set out the options. So your options are to not vaccinate, to wait for Pfizer doses to be available later in the year. And there are 40 million doses on order. So there will be Pfizer doses for people over 50 available by the end of the year if all things go to plan. Or to have the AstraZeneca vaccine right now. Where are you leaning? And then I'll respect your decision. And this is where you're sharing your recommendation. My perspective is I'd like to see you get vaccinated sooner rather than later. So whatever appropriate recommendation is for that patient. And then keeping the conversation going. If there's an outbreak and the risk of COVID does increase, let's revisit the vaccination question as an example of how to keep that conversation going. The next slide is an example of what my colleagues at the University of Sydney through the Ask Share No CRE have put together, led by Professor Lyndall Trevena, who's a GP academic. It's a brief decision tool for patients considering the AstraZeneca vaccine, and it's designed to be used in primary care with patients. So it describes what's involved, what the options are, who should have the vaccine, what are the benefits of the vaccine, using graphics which make risk easier to understand for people who may not have a high numeracy, and what are the side effects of the AstraZeneca vaccine. There's the URL for that. The slides should be available to you later on. And there's a brief YouTube explainer video from Lyndall as well. But what's useful here is to see that there's also those reasons for getting the vaccine and reasons against it. So that's what shared decision, it's a tool to support shared decision making. Now, just really briefly, I want to talk about responding to misinformation, and someone's Mr. Foyle from Foyle's Law. If you watch Foyle's Law, you'll know that he's very cool, calm and collected. He only really speaks when he needs to, and he's very smart. And I think that's the kind of approach we want to have when we're responding to misinformation. So particularly, for example, if you're on Facebook in your community and you're wondering what to do about something when someone has said something that's just wrong about vaccination. So be discerning, because sometimes if you respond, you can actually make more noise around misinformation than if you don't. Ask yourself, is it being shared? Is it being shared by someone who's influential? Is it affecting people's behaviour? Prepare people, if so, let them know. You might hear people say that the vaccine causes X, Y, and Z. Here are the facts. And so you fill that gap. You say it doesn't cause X, Y, and Z. Here are the facts. Let me share with you some quality information. Don't feed the trolls on social media in particular, because there are people out there who are either anti-vaccine campaigners or they're energised by having big debates about vaccination in social media. And if you feed them, you just give them more energy. Use trusted spokespeople or organisations to refute misinformation, and engage well. And this is a wonderful video from NACCHO, National Aboriginal Community Controlled Health Organisation, with Dawn and Pat getting their COVID-19 vaccines. Have a look at it. Just Google NACCHO. You'll find the video there on their COVID-19 resources. It's really straight talking. It's culturally appropriate. It's encouraging. It's telling people that they might hear misinformation. It's got all the ingredients, and it's wonderful to use influential spokespeople with communities in this way. So finally, some resources around all the things I've been talking about. You might find the Vaccine Misinformation Handbook particularly useful. And finally, of course, big shout out to all the nurses on the call tonight. Happy International Nurses Day. You are contributing to vaccination incredibly, as are the nurses on this slide who I have the privilege of working with. Thank you.
Thanks very much, Julie. That was very informative. Thanks, and I'm sure people will get quite a lot of ideas from that as to how to approach people who are hesitant. I noticed I'm just going to make a comment on this. There was a question about how to do this properly in a short 5-minute consult, and I think the answer with that is that you can't. And really, if you have someone who's really hesitant, who's turned up to be vaccinated, perhaps you have to book them in for a patient education consult and postpone their vaccination, because it's very difficult to go through all of that in detail and with sensitivity if you're rushed.
Kathy, can I just mention, I was on a webinar with Kerry Chant and Charlotte Hespy from the RACGP on Monday night, and they are looking at a Medicare item number for a consultation and vaccination together. So that's in the process of being discussed.
But remember that you're also going to be talking with people, your family, your community members about vaccination. And, you know, I use these techniques myself. You know, someone the other day said to me, my mum's neighbour said, oh, so what do you think about the COVID vaccine? And I said, I was just about to launch in and tell him what I thought. And I thought, no, well, what are your thoughts first? You know, just asking a couple of questions before you launch in. If that's all you do to figure out where someone is at, then that's going to make your time and more efficient, because you're answering the questions that person has, not the questions you imagine that they'll have.
Okay, few more questions then. I have someone asking, how do we respond to those whom have had side effects and they now say they're not going to have a second vaccine?
Well, we tell people who get significant side effects that before we immunise them, we actually inform them that if you get these side effects, you know, it may be that you're having a really good immune response, and that's really great. And so it changes it from a negative experience to a positive experience. I think the evidence is, though, that from the information we had earlier, is that actually with the AZ vaccine, people get a bigger response with their first vaccine, and the second one, they get fewer side effects in total. And because there's no evidence about mixing vaccine types and about immunity, we really need to stick to the one vaccine for the moment.
I'd just echo that. And I think, you know, as Julie said, it's actually about just asking the question, finding out a little bit more. You know, as Duncan said, just stepping through. You know, let's hope we talked about those side effects that you should have had. Definitely dose to Astra, much less reactogenic. But I think the other thing is that there are, you know, if people have genuinely had something really unusual, something you and your practice are concerned about, there is also a helpline. So it's 1-800 New South Wales Immunisation Specialty Service, so NSWISS, NSWISS, like Swiss cheese, NSWISS. Now, the aim of all of this and us sharing knowledge in this community is that, you know, it's only the most tricky cases that come to that hotline, but it is there for, you know, any of those patients that you really have those complex questions about.
And just following on from that, someone's asked, so if you have a patient who doesn't get side effects, do we have to worry that they're not developing antibodies?
No, you don't. You don't. And the good news is that, you know, there's not necessarily a correlation to that. You know, I can't really tell you why, but there's just not. The only thing what correlates with the reaction is your age. So if you are an older, you know, person like myself, you're less likely to be getting side effects than if you're quite young. But it's, you know, it's like everything in our world. Nothing's perfect. We don't always read the textbook.
And got more of a comment here, and I wonder maybe Julie might answer this. The comment says we need media to give accurate information and not put fear into the public and the negativities. And so perhaps a question from that is what can we be doing as a medical community to be trying to encourage the media to put out more positive and more accurate representation of risk in the media?
Call your local newspaper, engage with journalists, get to know them. You know, the media, all of us, I think, have done a lot of work with the media over the last year. I would say that the majority of journalists do want to do a reasonable job, but they have to fill lots of space each day, whether it be on the radio with time or whether it be an online newspaper. And they're looking for a fresh angle on everything. Giving your local media outlet feedback and calling in with talkback, giving positive examples of vaccination, and then just being engaged with your patients and communities so they've got access to you if the media information is poor quality is so important. But I would say actually that, having run some webinars with some of our major news organisations, they are committed to doing a reasonable job. They do have debates with each other in newsrooms about their editorial angles on these stories. And we just have to live with the media and immunise our patients against their scary stories.
All right. Here we have a patient, a doctor, or I'm not certain, I think it's doctor asking, yes, my 85-year-old patient developed a DVT 9 days after her first AstraZeneca vaccine. Platelets were normal, and I told her it's not related to the COVID vaccine, and she should still have her second dose. But how do I convince her to have her second dose?
Yeah, that's a great question. I think, so we have to remember that we do see DVTs, pulmonary embolisms every single day in Australia, and you've been managing those in your practice for years, patients that have had those. So, and they're not going away just because, that we happen to be giving out the vaccine at the same time. So I think if you were satisfied that she had a good clinical workup, the platelets were normal, if she had a D-dimer or, got investigated in that way, that was fine. Then you can reassure her that that's not this unique new syndrome that is part of, it's vaccine associated. I think if she's really uncertain, if you're at all uncertain, obviously there might, you could check in with a haematologist. You could think about, depending on when it was, looking for those antibodies. But I don't think that's the case. If she's gotten well, it's probably just your bog standard pulmonary embolus, and she is recommended to receive dose 2. And it's kind of probably having that conversation. Look, we've done all the tests to show this is a normal type of thrombosis. It's not the vaccine-associated thrombosis. We can tell you the difference from the blood tests we do.
And she's probably on treatment too.
Yeah. And if we have that patient, and this relates to another query here, who, they've had all of that explained, but they're flatly refusing to have a second dose. What sort of level of coverage can we say is realistic for them to expect after just one dose if they don't proceed? And I think that, Christine, you had some slides about that in your early presentation as to how much protection is afforded by the first dose, but just in quite simple terms for us.
Yeah, look, so AstraZeneca 1 dose, which has the longer interval, and it has been studied, around 70 to 80% protection. For post 1 dose, certainly out for that 3 months. Now, when you give the second dose with AstraZeneca, it's still around 70 to 80% protection. Obviously, the studies are looking at that now because you need time to pass. But even higher potentially in some settings. If you're looking at protection against severe disease, you're getting up to like closer to 90 to 100%. What the second dose probably does most for AstraZeneca is gives you that longer-term protection. So it lays down more immune memory. It's more like a booster in a way, whereas Pfizer is more like a 2-step process, closer together. The second dose of Astra is a bit more like a booster. And so you do need it. You do need it. But her choice, if she really didn't want to have Astra, if you went through everything, and she said no, then she'd be looking at, the waiting for a Pfizer vaccine, as Julie explained and Duncan explained.
Okay. I'll just say here that with all of these questions where people are hesitant, sometimes it does help to answer their questions, address the details, the clinical details, but then remind them of their options and the pros and cons of each option. So they're very clear on the trade-offs they face if they choose not to have a second vaccine or they choose to. Using shared decision-making, communicating your preference, but respecting their choice, but also perhaps engaging with them on the risks of not vaccinating and what that might mean for them individually, of not having that second dose and not having the assurance of the longer term protection.
All right, I've got a few technical questions. Someone's asking, is it worth checking antiplatelet antibody, full blood count and fibrinogen in people before they have the AstraZeneca vaccine, or is that excessive?
No, absolutely no need to. And nothing we can do at the moment is predictive of who will get this reaction. People have asked, should I give my patient aspirin, for a couple of days after the vaccine? Should I do this or that? No, it won't do anything. And PF4 antibodies are really interesting. They PF4 antibodies can occur naturally at extremely low levels, but absolutely don't do that. Can I also say, can I shout out to all the nurses on the line too? Because I had the privilege of working in the hospital today, and I got to walk around and say Happy International Nurses Day to everybody. So I really did want to add that as well. It's a special day.
Okay. And so following on from that, a lot of patients coming in, and when you mention the blood clot situation to them, they say, well, I'm on aspirin, or I'm on warfarin, or I'm on Xarelto, so I'll be all right. And I suppose we're having to sort of explain to them that that's not necessarily a protective factor, or perhaps we just don't say very much if they feel more confident.
I think the thing to them to say is, look, that's good for the condition that you're being treated for, that we're giving you that for. But actually, this is a really unique new condition, because I think, as Julie said, and it's a beautiful slide, that patient's going to go home with what you've told them. They might be telling, I got the vaccine and I was okay to get it because I was on these anticoagulants. My doctor, nodded when I said that. But you mightn't be, because you're not on those anticoagulants. So you wouldn't want the converse to happen, So I think it is still, if you can, and I respect the time constraints, that opportunity to say, actually, this is really rare, really unique new condition, and it's so unusual, we can't predict you'll get it. But so we're recommending the vaccine, obviously, to so many, everyone really.
Okay, and I have a question. Someone is a GP under the age of 50 who had the AstraZeneca initially before there was the recommendation not to, now has the option to have a Pfizer vaccine, because now it's being made available. What's the recommendation for that person who's under 50, who's had the first dose of AstraZeneca, I presume hasn't had any side effects or significant complications? Do they proceed to their second AstraZeneca dose, or should they switch and have the Pfizer?
Well, I think we're all
second dose.
Second dose AstraZeneca. And, we had a chat with the residents here, actually. They were all asking the same thing, all of our junior trainees. And, it's extraordinarily rare, this condition after that second dose. And, we have knowledge about the boosting with the second dose of the same vaccine. We actually don't have knowledge of the safety and efficacy of mixed schedules so much. Go with what we know.
Okay. I'm just scrolling through because we still have lots of questions coming in. There's a question again about how long does the vaccine last for? And I think you've talked again about boosters being likely to be necessary and potentially tweaked versions of the vaccines coming in the future. I presume at the moment that we really don't have a clear answer for that right at this point, but that will probably evolve over time.
Yeah, look, absolutely. I mean, there's thousands and thousands of scientists studying this as we speak, and we've only had the virus in the world for, I keep always looking at the months, 15 or 16 months. So protection's looking good out to 6 months with antibody levels. Pfizer, for example, they're doing a booster study right now. They're doing a 6-month booster study, and they're boosting with one dose of exactly the same vaccine, and then they've got another arm of the study where they're boosting with a tweaked Pfizer vaccine that is tweaked for the variant, the South African variant. Moderna are doing a booster dose study, and they're doing a booster dose study where they've mixed the variant vaccine in with the regular vaccine, and they've actually got half the amount but mixed together in the vial, and that's their boosting strategy, and they're doing that in some patients. So these studies are being done right now to see if we'll need a booster, but we don't have any recommendation on that.
One scenario that Andy Pollard mentioned in his webinar, Christine, tell me if I'm wrong here in my recollection. So Andy Pollard was the chief scientist who trialled the AstraZeneca vaccine at Oxford University. And he said one possibility is that we have another vaccine, so we have our first 2 doses, and then in future, to cover other variants of concern, we have another dose that covers those variants. And by then we have COVID under control enough to control the variants so that we don't need to keep having more vaccines against those. And if we assume that the duration of protection against the existing variants that it protects against now is there, then it may be that we only need 1 booster in our lifetime. But it's just, we're still having to deal with that uncertainty. It's just not known. And we watch this space, it will be learnt. But right now, they're still studying that question.
Okay, and I was going to just add to that. The reason we've got variants giving us such a big problem is because the virus is just spreading in an uncontrolled way. So we know when a virus replicates, there's a subtle change in its genetic makeup each time. If we have uncontrolled transmission, we'll have more and more variants. So we've got to get that transmission down.
I think I maybe just have time to address one more that someone asked earlier on about rural areas and vaccine hubs. Does anyone know if there's any plan for Pfizer hubs or in the rural areas, or are people going to be asked to go to metropolitan areas to receive Pfizer for the under 50 age group?
Look. Oh, Duncan, go ahead, please.
Well, what I know is we're in Bega, we're a rural centre, and because we did use the Pfizer vaccine for the 1A group, we will be able to use Pfizer as a rural hub from the 24th of May. So I suspect, and I don't know, Christine, you might know more, but wherever there was a rural hub previously, they were likely to be able to do the same for those under 50.
Excellent.
Yeah, I think more rural hubs for Pfizer will definitely be opening up. I mean, they have to. We can't. People from Bega and Narrabri and Orange aren't all going to come to Sydney, so they are going to open up. It's just that the supply of Pfizer is, steady. Bit more tricky. But the good news is Pfizer's getting more what we call thermostable, so it can last a longer period of time now in the refrigerated temperatures if necessary, and at even -20 if necessary. So there's more options opening up for the Pfizer.
Okay, well, I think we're going to have to start wrapping it up. I would like to, on behalf of the New South Wales and ACT Primary Healthcare Network, thank all of our speakers for participating and providing us with really up-to-the-minute, reliable information about COVID vaccine safety, and for helping us to think about some useful strategies for talking to our patients and addressing that vaccine hesitancy. There's going to be information that was linked in the chat box, and there are links there. And I understand that this webinar has been recorded and will be available through Coordinare within the next few days and will be circulated. So anyone who couldn't watch everything or listen to everyone, or who wants to share it with other people, and perhaps sharing this with some of our specialist colleagues will be a good idea, because unfortunately, they're not expert on everything, and they've been giving sometimes some inaccurate advice to their patients. So I think we do need to make sure that the correct information gets out across the medical profession. So thank you to everyone who joined for the webinar. Thank you for all of your questions. And I'd just like to finish off by saying that, as healthcare professionals, we all have to play our part in trying to keep Australia safe. And if we can achieve high vaccination rates here, it's going to protect our local communities, our national communities, but also we have to think about our part as global citizens and realize that vaccinating here is going to have a beneficial effect in bringing COVID under control worldwide. So I think we have to keep that lofty ambition forefront and just press on, vaccinate as many people as we can, and each one is a victory. So that's fantastic. Thank you all for your help, and thanks again for organising this webinar. Thanks very much.